and welcome to our episode on heart disease and heart failure as part of Heart Health Month. I'm your host, Dr. James Beckerman, cardiologist and medical director of heart programs for Providence Heart Institute here in Portland, Oregon. As a reminder, the information provided during this event is for educational purposes only. If you have any questions regarding medical conditions or treatment plans, please consult your physician. So let's get started. I'm thrilled to be with all of you today and incredibly psyched to be with our current guests. We have Dr. Jacob Abraham and Dr. Joshua Remick, both cardiologists as part of the Providence Heart Institute. I'd love it if each of you guys could just introduce yourself to everybody, share a little bit what you do and how you spend your days. Jacob, why don't you start?
Thanks, Jamie. It's a pleasure to be here. My name is Jacob Abraham. I am the section head of the Advanced Heart Failure Program at Providence St. Vincent Medical Center in Portland. I spend my time treating patients with the most severe forms of heart failure. And outside of work, I enjoy exercise and spending time with my family.
Great. Josh?
Thanks, Jamie. I am Josh Remick. I am a heart failure cardiologist, and I joined Providence about 8 years ago. And I'm from Vancouver, British Columbia, so a native Northwesterner, and was very excited to come back to the Northwest. Like Jacob, I enjoy exercise, being up on the mountain skiing, and spending a lot of time with my family and 2 dogs at home.
Fantastic. So we're here to talk because it is Heart Month, February, and you guys, as they say, have a certain set of skills, being primarily cardiologists who take care of patients with this condition that is terribly named heart failure. And so I would love to go straight off. Jacob, maybe you can get us centered here as to what heart failure is and what it's not.
Well, Jamie, as you said, the name heart failure or the term heart failure is really a terrible and very scary term. When we talk about heart failure, what we really mean at the most basic level is that the heart is unable to pump enough blood to the body under normal hemodynamic conditions. But that doesn't mean that your heart is stopped. It doesn't mean that you're having a heart attack or cardiac arrest. It simply means that the heart can't do what it's supposed to do under normal circumstances. And for patients, what that may mean is that they experience fatigue or shortness of breath, perhaps with moderate exertion. Some patients who are experiencing mild heart failure may only experience symptoms under the most extreme exertion. Some patients have no symptoms at all, and heart failure is really just a label that's applied because they have abnormalities that are subtle on imaging studies or by lab work. There are a few patients who certainly develop the most severe forms of heart disease and do require advanced therapies such as heart transplantation or the insertion of a mechanical heart pump. But fortunately, that's a minority of patients.
So it really runs the gamut. Sometimes when I talk to patients, I try to frame things into ways that I can easily understand. Sometimes I kind of use the analogy of the heart as like the engine of your car, and the idea that, you know, maybe sometimes you want to take your car out on the highway or go off-roading or do different kinds of things. And if your car isn't able to meet those needs, then that's kind of akin to the issues that we have with heart failure. So it's not necessarily a true failure. It's just that the function of the heart is not optimized to meet the needs of the body. So Josh, when I get into a conversation with a patient about heart failure, the first question that people often ask is, oh, so that means that my heart is weak. And I'd love for you to break down for people the idea that there's different types of heart failure, and just kind of take us through that a little bit.
Yeah, so it's true. There are, in broad strokes, sort of 2 types of heart failure that we see patients with. Generally speaking, we're talking about roughly 6 million people in the United States who have this disease, and it breaks down about equally 50-50 Those who have a, so to speak, weak pump where the heart doesn't squeeze particularly well, we call these patients or diagnose them with what's called systolic heart failure. And then there's the population where the heart squeezes fine on imaging studies, but they still have symptoms of heart failure. And this is usually a result of the heart not relaxing well. It doesn't unload properly after it contracts. And those are often referred to patients with diastolic heart failure. And so typically the symptoms are, universal. Like Jacob said, they can have fatigue or shortness of breath, particularly with exertion. They can have symptoms of swelling or what's known as fluid retention. But the treatment for the different types of heart failure are somewhat different and somewhat unique depending on the particular type that we're describing.
Yeah, that concept of what you call diastolic heart failure, where the heart is squeezing well, but it doesn't relax as well. I feel like that's a hard thing for a lot of us to get our minds around. One of the ways that I sometimes think about it is if your job was to blow up a balloon and somebody decided to wrap a piece of tape around that balloon, even though you had the force to try to inflate it, there's just something restricting it because it's not as elastic as it should be that makes it harder for it to function the way that it's supposed to. So when we think about the different ways to treat heart failure, it starts with prevention. And I would love it if, Jacob, you could get into a little bit how we can prevent heart failure. And honestly, if we have a very early stage of it, how lifestyle changes can help us maybe to be delayed from reaching those later stages.
Absolutely. It's an important question. So, first of all, one of the most common causes of heart failure in Western countries or developed countries is coronary artery disease or blocked heart arteries and heart attack. So we know that some of the most common risk factors for developing coronary disease and heart failure that can result from it include elevated blood pressure, diabetes, smoking, and being overweight. And those are all factors that are within a person's control to either eliminate in terms of smoking or to try to control in terms of blood pressure and diabetes. And for other patients who don't have those types of heart failure, those same aspects of self-care are still really important, not only because they affect the blood vessels, but they also help or affect the heart in other ways. So taking care to maintain a healthy body weight, avoiding excessive alcohol, treating other risk factors, as we've mentioned. I might also add to that list conditions like obstructive sleep apnea, which itself are associated with being overweight, are all contributors to the development and the progression of heart failure of any variety. And so these are really important to try to target in addition to the medications.
That's great. So Josh, one of the things that we talk about a lot as cardiologists when we're counseling our patients about healthier diets is we get into this conversation about salt. And I'd love it if you could break it down a little bit. How much salt should we be eating? What's the concern if we have too much? Don't we need some salt in our diets?
Yeah. I mean, it's true. There's been a lot of focus on salt, and generally speaking, a Western diet is pretty salt heavy. And we know that dietary sodium or salt increase can lead to not just symptoms of heart failure, but it can raise blood pressure and it can lead to all sorts of other health consequences. And the reason it's particularly important in patients who have a diagnosis of congestive heart failure is, as I like to explain to a lot of my patients, water follows salt. And one of the main symptoms for patients with heart failure is water retention or feelings of congestion. It's in the name. And it sort of follows that if you can limit your dietary sodium, or again, salt, then you've got a better chance at keeping your body's fluid balance in check. So when I first went into training for heart failure, the mantra was as low sodium a diet as possible. But over the last couple of years, we've actually learned that that can be detrimental. You do need some salt in your diet. And so nowadays, we typically recommend roughly 3 to 4 grams of sodium per day in your diet. Now, most people, like myself, are not walking around with a measuring cup and measuring how much sodium and putting it on a scale you're putting in your body. So what I typically tell patients is if you go to the grocery store and you're sticking to the outside edges of a grocery store, that's your fruit, your vegetable, your fresh meats, your fresh fish. If you're doing that and you're cooking most of your meals, you're going to be just fine. And if you're not adding a ton of salt using a salt shaker when you're cooking, most people are going to do just fine in terms of limiting their sodium within those expected or sort of recommended ranges.
That's really helpful. I remember when I learned as a medical student or maybe as a resident that only about maybe 10% or 20% at most of the sodium that people get from their diets is from a salt shaker. Salt that they use to flavor their food once it's prepared, or salt that's involved when they cook it. It really seems to be the majority is from processed foods, prepared foods, restaurant foods. And so even though people out there might think, hey, I'm doing a great job, I don't have a salt shaker on my table at home, they still might be getting a lot of salt if they're purchasing a lot of canned soups or frozen meals that they heat up later, stuff like that. Jacob, so Josh said that wherever salt goes, water goes. And I've had some patients say to me, even patients with congestive heart failure say, well, I want to get that salt out of my system, so I should just drink more water and basically flush things through, because there is this idea out there in the world that water is this healthy thing, that it cleans you out, so to speak, flushes out all the toxins and stuff like that. So how can we get into trouble potentially using that kind of thinking when it comes to congestive heart failure?
I love this question, Jamie. I hear that a lot, and it's important for the listeners to recognize that the body, and in this case, the kidneys in particular, are very effective at eliminating excess fluid. But on the other hand, they're also very effective at conserving and maintaining what we call homeostasis. The amount of fluid that the body needs is very tightly regulated. So if you drink excess water, you're simply going to remove it in your urine, and there's no need for you to be concerned about flushing out the system, because the kidneys do a tremendous job without any direct input from us. So as Josh mentioned, one of the major manifestations of heart failure is the tendency to retain fluid. And with our Western diets, which tend to be high in salt, we can retain fluid. And if we drink water or other fluids in excess, that will allow for even further buildup of fluid, either in the lungs or in the extremities in the legs. And so we see many patients who are presenting with symptoms that are directly related to the retention of initially salt, but the consequence of fluid retention is what drives most of the symptoms and what leads to the term congestive in the name congestive heart failure.
That's right. So whenever we talk about diet, the other thing that we talk about in the same breath is typically exercise. And Josh, if you wouldn't mind breaking down what a general, reasonable exercise recommendation is, not just for people who might have heart failure, but for everybody else. What should people be aiming to do?
Yeah. What I try and counsel most of my patients on is to just try and be as active as you can in your daily life. It's great if you can make it to a gym and you can work out, every day on an elliptical or a stationary bike or a treadmill and do, lightweight exercises. But really, we should be aiming for at least 30 to 60 minutes of activity a day. And I tell my patients that doesn't have to be at a gym. It can, and it doesn't necessarily have to be 60 continuous minutes a day. Do simple things like take the stairs, up to the second floor where your office is instead of the elevator. Park at the back of the parking lot and walk into the grocery store. Things like that to increase your daily activity and get your steps in, so to speak, can be really, significant in altering the trajectory of patients' cardiovascular health. And so those recommendations are similar to what we recommend for patients, whether they've got no heart disease, or a diagnosis of congestive heart failure. Aerobic or exercise, movement activity, 30 to 60 minutes a day, where they just get their heart rate up a little bit and push their bodies out of their comfort zone is kind of what I would recommend.
I like that you mentioned that idea of pushing your body a little bit out of your comfort zone, because I think we all remember, especially from middle school or high school gym class, that exercise sometimes feels a little bit uncomfortable, and that's okay. Obviously, there's a safe and unsafe version of being less comfortable, but it's during those times when you push yourself a little bit that you do start to achieve growth and improvement. And so, in addition to just moving our bodies in a regular, casual way, it's nice to think that we can also grow and improve by putting forth that little bit of extra effort. While we're talking about lifestyle issues here, we have a question about a genetic condition that actually can predispose people potentially to heart failure. It's called familial hypercholesterolemia. And I was wondering, Jacob, if you could just share briefly, what does that long phrase even mean? And how could it potentially put somebody at risk for developing heart failure?
Absolutely. So we can break it down. So familial hypercholesterolemia. So hypercholesterolemia is simply elevation of blood lipids, so high cholesterol. And then familial means that it's inherited or genetic. So there are multiple different types of familial hypercholesterolemia, but at the end of the day, they all result in a high cholesterol panel with typically an elevated bad cholesterol and low levels of the good cholesterol. Now, as part of general health maintenance, most patients who are over the age of, say, 30 should have their cholesterol checked periodically. And that basic lab test would indicate whether someone had an elevated cholesterol. It's certainly part of the evaluation of somebody who has heart disease in general and heart failure specifically. Now, an elevation in cholesterol we know is one of the strongest risk factors for developing coronary artery disease. And as I indicated earlier, blocked heart arteries, coronary artery disease can be a major reason in modern countries for patients to develop heart failure. So identifying and treating an elevation of the cholesterol is a very important step in reducing one's risk for heart disease in general and heart failure specifically.
Yeah, it's a great point, and I really appreciate that question was asked, because it speaks to the idea that in addition to just going about in our daily lives and trying to eat a healthier diet, trying to stay active, there is this idea of having some health maintenance. And so part of our jobs and responsibilities in trying to be healthy people is keeping an eye on these silent risk factors like blood pressure, like cholesterol, that people generally aren't going to have symptoms of, but especially as we age, may become more in the picture. And a simple blood test can tell you a lot about your potential risk. And depending on what the results might be, might even give you some insight as to whether you have a more familial or genetic component of this, and might even want to talk to family members about getting their cholesterol screened as well. So we've talked about prevention a little bit. We've talked about lifestyle a little bit. Then there are medications, because, as much as we'd prefer not to have to recommend that anybody take a medication, sometimes it may be appropriate to help them have a better quality of life and to live longer. The medication that I want to focus on with you guys is the diuretic, the water pill. Tell me, Josh, why do we prescribe these, and why are they sometimes important for people to take?
Yeah, so they are often quite important for patients with congestive heart failure. And we don't prescribe them because we are evil and we're mean, even though we recognize that when a water pill works, it can be uncomfortable, and it can cause impairments in your quality of life. But the reason we prescribe them is because they are very effective at reducing congestion. Again, they stimulate the kidney to excrete excess fluid. And the main driver of symptoms for the majority of patients with congestive heart failure is an excess in fluid in the body. And we need to drive that fluid out so patients have improved breathing. They're not swollen or feeling bloated. They don't have swelling in their legs. And they can be incredibly effective at making patients feel better, despite the fact that when they work fairly effectively.
Absolutely. And I think it's important for people to realize that if they have been prescribed a water pill or a diuretic, there's a lot of thinking as to why they should be taking it, what the appropriate dose should be, and to stick with it. Because even though it can be absolutely inconvenient sometimes to take these medications, they can be the difference between sometimes even being hospitalized and not being hospitalized. So we've talked about prevention a little bit, lifestyle, little on medication. And then we get to some of the more advanced treatments. And people are always interested in kind of what's new, what's next. And there's two different aspects of these advanced treatments that I thought we might get into a little bit. One, I'll describe as mechanical support for the heart. And the second is heart transplant. And so I'm curious, Jacob, if you could take us through a little bit of what we do for patients today in terms of mechanical support for their hearts if they're having a difficult time.
So mechanical support for the heart actually has a very long history, but if we think about what's available most recently, there have been incredible advances in engineering and technology that allow patients to live long lives, even on some of these support devices. So the most common type of support device that we're talking about is what's called a LVAD, or left ventricular assist device. And basically what that means is that a heart pump is actually directly inserted into the native heart. So the heart's not removed with these most common types of pumps, but it's actually inserted into the heart and essentially takes over most of the work of the heart. These devices allow patients to leave the hospital, allow patients to resume an active life. They do come with some barriers or some burdens. These include equipment to power the device that have to be carried. So there are, batteries that are about the size of one's phone that have to be carried, and a controller. There is, at least in the current generation of devices, a small tube that exits the body to connect the internal pump to the power sources and to the computer that drives it. But as I mentioned, patients who are supported with these types of pumps can live for a long time, 10 years or more in the best circumstances, and can oftentimes resume a very active and healthy lifestyle, including exercise.
I remember even as a kid, before I knew that I was going to go to medical school someday, I remember hearing people talk about on TV of the idea of an artificial heart. The idea that you would take out a person's heart and put in this machine that would fully replicate the activities of the heart. Do you think that'll ever happen? Do you think we're close to it?
Well, in fact, it's not science fiction. The total artificial heart has been a reality since the 1980s. Some of our listeners may remember Barney Clark, who was the first human to receive a total artificial heart, I believe in 1982, around there. And since then, total artificial hearts have been a mainstay of treatment for a very select group of patients who are not eligible for the LVAD or may not be immediately eligible for a heart transplant. And so there are hundreds of patients every year who are implanted with those devices, usually as a means of supporting them until they can go on to get a heart transplant. But it's not science fiction. And like the VAD, the engineering continues to improve. These devices are getting smaller and they are improving. So we may see that as time goes on, more and more patients receive those types of support devices as well.
Yeah, I mean, it makes sense that with, like you held up your phone earlier, the phones keep getting better and better, and so do the hearts. But these artificial hearts do retain some inherent challenges, right? They have to have a power source. There's a potential risk of infection. There's a risk of blood clotting inside the device. And so even though we're excited about all the progress we're making in mechanical support and even in artificial hearts, heart transplants have also developed into a very important and somewhat accessible option for people who need them. Josh, can you talk to us a little bit about heart transplants? How many are done out there, and what can patients expect if they get a heart transplant in terms of the next chapter of their lives?
Yeah, I mean, transplant has been a mainstay of therapy in our field for the sickest of patients for well over 40 years. And we've got, a long experience doing these kind of surgeries for patients. And quite frankly, it can give them their lives back, for lack of a better expression. I mean, they get not just longevity, but they get quality of life back that they had lost because of their progressive heart failure. The problem with heart transplant is that hearts are not grown in a lab. They're not manufactured in a factory like an LVAD is, and so there is a limited supply of available organs. Typically, in the United States, we're doing, around 3,500 heart transplants a year, and the donor pool, as we say, has been growing slowly in the last couple of years, but it's not nearly enough donors to satisfy the number of patients who are so sick that they require that therapy. And I will say it is a fantastic therapy, but it is not a therapy without its own set of complications. We are putting an organ from another individual into your body, and we do our best to match that organ in terms of size, in terms of blood type, in terms of various immunologic factors, but it is not you. And as a result, we have to give you medicine to prevent your own immune system from attacking something foreign in your body so that that organ, that heart, can function as normally as possible. And so there are complications from that as well. But for patients who are at the far end of the spectrum, who are in need of this therapy, it can be a lifesaver.
It sure can. And it's important for people to recognize that the number of heart transplants done in the United States year to year has been fairly flat over the past several decades. And so to the effect that you can sign up to be an organ donor and be part of the solution, I think is a great thing. One last thing I wanted to quickly mention is that people may have seen in the news information about a person having a heart transplant from a pig on the East Coast. And that opens up another incredibly exciting conversation about what might be possible in the future to help satisfy this need for donors down the line. But for now, I just want to thank you guys so much, Dr. Jacob Abraham, Dr. Josh Remick, my colleagues and buddies. I'm just so happy to have the opportunity to talk with you guys and learn from you like I do every day. And thanks to everybody out there for listening and for participating, by sharing questions with us. Remember, if you are looking for medical advice, please contact your own physician or visit providence.org, and make sure to follow Providence on social media at Providence on Twitter and under Providence Health System on Instagram, Facebook, and LinkedIn. Thanks so much, everybody.